my esteemed colleague, Dr. Emily Littlejohn. She, just a brief bio on her, she completed her internal medicine residency at Loyola in Chicago and her rheumatology fellowship at the University of Michigan. In addition, she received a MPH from the Boston University in epidemiology. She worked closely with lupus patients, I think, during her fellowship and continues to do so, and became interested in this complex and elusive disease. So she joined the medical staff in the Department of Rheumatic and Immunologic Diseases at Cleveland Clinic in 2017, and is a clinical assistant professor at the Cleveland Clinic Lerner College of Medicine. So she will be, she's also the director of the lupus cohort, a longitudinal biorepository that banks the blood and urine. Also the director of the lupus clinic at Cleveland Clinic main campus. In today's lecture, she will be discussing advances in biologics in lupus. Dr. Littlejohn.
Thank you, Dr. Chatterjee. Welcome back from lunch. So it's really prime time for lupus. It's very exciting. You know, May is Lupus Awareness Month. May 10th was World Lupus Day. And I'm here to tell you that it's also prime time for emerging therapies and particularly biologics in the treatment of lupus. So what I'm going to do today, I'm going to take you through the challenges of treating lupus. I'm going to review how far we've come. I'm going to review recently approved medications the last 3 years, and then a preview of where we're going. And then we'll finish up with some of my personal thoughts. So why is lupus so difficult to treat? Anyone who's treated a lupus patient here knows that it's a very heterogeneous disease, both clinically and serologically. We all know that the patient who has cutaneous rash and a positive ANA with a positive SMIF has just as much lupus as a patient who has pleural-C or lupus nephritis and a positive chromatin. The heterogeneity of this disease makes it very difficult for targeted treatments, as we don't have consistent and persistent targeted therapies. So before we talk about treatments, let's talk a little bit about the pathogenic mechanisms. And I think we've seen this slide in some respect already in the last 3 days. So the pathogenesis really starts when there are autoimmune responses that are initiated by immune recognition of autoantigens. This is usually derived from apoptotic material from dead or dying cells or cell debris. These autoantigens are presented to self-reactive T cells, which provide help to B cells, resulting in cellular activation and the production of pathogenic autoantibodies. The autoantibodies bind to circulating autoantigens and form immune complexes. These engage Fc gamma receptors on plasmacytoid dendritic cells, or PDCs, which leads to internalization via endocytosis. Intracellular toll-like receptors are activated by these immune complexes, resulting in type 1 interferon production, which is pivotal in the pathogenesis of lupus, and we'll talk a little bit more about later. So this chronic immune activation by interferon causes excessive production of more interferon and other cytokines. They promote production of B cell survival cytokines like APRIL and BLyS, which you might sound familiar to you in our recent targeted pathways. And they contribute to activation of T cells and differentiation of monocytes into dendritic cells. So many cytokine receptors, including type 1 and type 2 interferons, activate JAK-STAT, and they drive transcription of interferon-stimulated genes. And this creates a positive feedback loop for inflammation. So in this schematic, you can see what I'm describing here. The process sort of is self-perpetuating going forward. And as you can see, there are also on this schematic different areas that have already been targeted, such as B cell rituximab, obinutuzumab, which we'll talk about, things such as belimumab, voclosporin is up here with the T cells, and things like anifrolumab, which have been recently approved. So let's talk about previously approved medications for lupus, of which there are not many. You can see quinine, which was described in 1894. Really was born, hydroxychloroquine was born of the idea of this anti-malarial, which was FDA approved officially in 1958. Aspirin, described in 1898, was officially FDA approved in 1948. Corticosteroids, as we know, cyclophosphamide, which is approved for nephrotic syndrome in 1999, and most recently belimumab, which was FDA approved for systemic lupus in 2011. This is a pretty scant list. So in 2020, we have what's called the lupus renaissance. And at this time, it was very exciting for lupologists because we had the advent of a few new medicines. The first one was belimumab that was approved for lupus nephritis, and that was in 2020. Voclosporin, which was approved for lupus nephritis in 2021. And anifrolumab, which was a novel targeted antibody approved for systemic lupus in 2021. So in my brain, this is how we treat lupus. We now have these 3 new medicines, belimumab, anifrolumab, and voclosporin, to treat the many systemic manifestations of lupus. This is in addition to these other medicines that we have. And frankly, this is a very overwhelming slide, but we're still really not doing a very good job. Our outcomes are still really not where they should be for how many medicines that we have to treat lupus. So where are we going? This is a systemic review from March of 2023, done by Laurent Arnaud in Joint, Bone, and Spine. And this is a really great schematic of all the different therapies in which phases their trials are currently in. So if you look in the outer rings here, you can see which targeted pathways we have. It spans everything from B cells to complement to plasmacytoid dendritic cells, cytokines and chemokines. The internal circle is phase 1, or the external circle, I should say. The most inner one is phase 2, and as you go inward, there's phase 3, and then the marketed, which we see here are anifrolumab and belimumab. This schematic shows a few of the medicines that I want to highlight today. The first one being littlejohn, the second one being interferon kinoid, iberdomide, obinutuzumab, ianalumab, and deucravacitinib, which has gotten a lot of talk today already. Finally, we'll finish up by talking about CAR T-cell therapy. So these are the 6 that I mentioned. So let's start here first by talking about these therapies that affect the interferon pathway. And no lupus talk would be complete without mentioning interferon and how important the pathway of interferon is in this disease. We know that there are increased levels of interferon in serum of patients with lupus, and we can attribute these levels to a lot of the B symptoms that we have in our patients with lupus. They're associated with these viral infectious symptoms such as muscle and joint pain, headache, pleurisy, fatigue, and fever. It also has a suppressive effect on the bone marrow, resulting in anemia, neutropenia, lymphopenia, and thrombocytopenia, so a lot of the cytopenias that we see in these lupus patients. The lupus disease activity correlates with interferon alpha levels and the strength of the interferon signature. And we know there are many inducers and regulators of the interferon alpha production by this plasmacytoid dendritic cells. I'm not going to go through all of them, but they're all listed here below, and also you can see them in the schematic on the right. So a lot of potential targeted treatment pathways. So the first one that we'll talk about is littlejohn, or BIB059, which is a humanized IgG1 monoclonal antibody that's targeting blood dendritic cell antigen 2, or BDCA2. The second one is interferon alpha kinoid, which is an immunotherapeutic vaccine. This is composed of an inactivated interferon alpha to a carrier protein that generates endogenous polyclonal antibodies to block interferons, so these free-floating interferons. So on the left here, we'll talk about the trial for littlejohn here, which the first trial was actually done in cutaneous lupus erythematosus patients. There was 132 patients, and the primary endpoint here was a decrease in class C2 score by 50%. This trial did meet endpoints, and that there was a decrease in these class C scores at week 16, which was an endpoint that was changed from week 12. And you can see here that the change from baseline was pretty high, negative 38.8, negative 47.9, and negative 42.5 from baseline amongst 3 different doses. This is compared to a placebo effect of negative 14.5. So pretty good response in our cutaneous lupus patients. In terms of the active joint, which was a secondary trial that came out of this first one, these patients did meet primary endpoints, which were a decrease in the number of active joints at week 24. You can see here that the change is not as significant as in our cutaneous lupus patients, negative 15 versus negative 11.6 in the placebo group. So great for skin, potentially not as exciting for joints. In terms of safety, there was 2 cases of herpes zoster and 1 case of herpes keratitis. Now the story with interferon alpha kinoid is not as exciting. It received fast track designation in 2016. The phase 2b trial showed promising results, including induction of neutralizing antibodies against interferon, a decreased interferon signature in these patients, improved fatigue, and reduced steroid dose. However, it did not meet its primary endpoint, which was a BILAG-based assessment with a corticosteroid tapering regimen, and the trial was terminated. So the status of a phase 3 trial right now is uncertain. So the next medicine is iberdomide, and this is also a medicine that affects the interferon pathway. This is an immunomodulatory IMID drug, similar to those such as thalidomide or lenalidomide, and it promotes degradation of transcriptional factors Akeros and Ios, reducing activity of B cells and type 1 interferon pathways. In this study, there was 288 patients with lupus, and across 3 doses of this drug, they gave these patients drug, excluding those with active neuropsych lupus or lupus nephritis. Now, despite excluding those patients, these patients were actually quite sick. All of the SLEDAI-2K scores were greater than 6, with a mean of 9.6, and most of us consider 8 or above very active. This study did meet primary endpoint, which was a SRI-4 response at week 24. In terms of safety, there were upper respiratory tract infections and urinary tract infections and neutropenia in many of the patients. Now, after the study came out, this phase 2 trial, there was an editorial put out by Karen Konzenbader, who is a thought leader in the lupus field, and this was in March of 2022. And she was just urging everyone to sort of temper their excitement based on some of the red flags that she saw in this trial. She notes that only 72% of these patients were white and 7% were Black. And there was a large lack of racial diversity, which is a general problem amongst all lupus trials. She mentions that 24 of the patients who received the middle dose, the 0.3 milligrams of this drug, discontinued treatment for reasons that included adverse events and withdrawal from the trial, with not a lot of other explanation beyond that. She notes that most of the secondary endpoints were not met that I listed here. In addition, and probably the most concerning side effect here, adverse event here, was that there were many fungal and viral infections, including 77% in those who received the drug and 65% of those who received the placebo. So generally, there is a signal here for infectious events. I'm not sure about those 65% who received the placebo. I would venture it's because they were very sick patients to begin with. Next is obinutuzumab. So we all know that randomized controlled trials of type 1 anti-CD20 antibodies, which include rituximab, failed to demonstrate complete renal response in lupus nephritis, which is surprising to many of us in the lupus field. But we know that humanized type 2 CD20 antibodies provide greater B cell cytotoxicity and depletion. Now you might ask, what is the difference? And here's a picture depicting the difference. On the left here, you see type 1, and on the right, you see type 2, whereas the type 1 are partially internalized and type 2 are not. So this is the Nobility trial, which looked at obinutuzumab in patients with lupus nephritis. These patients had class 3 and class 4 and were all on background CellCept. What they found was that these patients did meet primary endpoint, which was complete renal response at week 52, with further improvement seen by week 104. 40% of patients who received obinutuzumab with standard of care achieved complete renal response, compared to 18% of patients who received placebo with standard of care. Complete renal response here was a UPCR of less than 0.5. Obinutuzumab resulted in greater improvements of baseline C3, C4, and anti-double-stranded DNA at weeks 4 through 104, and we saw further improvement of the urine protein to creatinine ratio at weeks 52 through 104. So there was a sustained response in these patients. One of the major limitations of B-cell depletion to date as a lupus therapy is that the subsequent increase in B-cell survival cytokines that promote expansion and autoreactivity of B cells, which can lead to relapse. We don't have good data to show that over time these B cells stay quiet or stay at low levels. So here is that data that I just described. You can see that complement levels rise over time. The UPCR nicely drops here at week 36 and 52 and is sustained through 104, in addition to the eGFR, which continues to rise. The next medicine has gotten a lot of press in the plaque psoriasis world. It was recently approved for psoriasis, and this is deucravacitinib. This is an oral selective TYK2 inhibitor that binds the regulatory domain and locks the enzyme in the inactive state. This inhibits downstream signaling mediated by type 1 interferon, IL-10, IL-12, and IL-23. Here's a depiction of that. So this is the PaiSLey trial, which is a phase 2 trial. And in this study, there were 336 lupus patients. They were randomized across 3 different doses of this medicine, 3 milligrams twice daily, 6 milligrams twice daily, and 12 milligrams once daily, or placebo. And the primary endpoint was the SRI-4 response at week 32. Secondary outcomes assessed at week 48 included the SRI-1 again, the BICLA response, the Class E response, which again is a cutaneous skin response, the LLDAS, and improvements in active swollen plus tender joint counts. So here are the results of this study, and there's a lot of domains they looked at here, but if you just focus on the SRI-4, you can see that response rates were higher with deucrictibant for the BICLA, the Class E 50, the LLDAS, with the SRI 58.2% versus 34.4% in the 3 milligram BID dose, which is the lowest dose that you see here. In terms of safety, there were higher rates of respiratory tract infections, nasopharyngitis, headaches, UTIs, and other cutaneous events, which I think were also noted in the psoriasis trials, including rash and acne. And the last one that I'll just mention briefly is ianalumab. And this is a human monoclonal antibody with dual mechanisms of action. There is competitive inhibition of BAFF by BAFF receptors, binding receptors, and the elimination of BAFF receptor B cells by antibody-dependent cellular toxicity. Very difficult to find the phase 2 data on this trial. So I'll just mention we need to kind of keep our eyes out here for these 2 trials. One is a phase 3 looking at ianalumab in those with systemic lupus, which is the serious SLE1, and also in those with active lupus nephritis, which is serious LN. So next I want to talk about one of the most exciting things happening in this field, and I know Georg Schett had an excellent presentation on this the other day. I think it was yesterday morning. So let's talk about CAR T therapy. So chimeric antigen T cells are considered living drugs. And this therapy is when the chimeric antigen receptor T cells are genetically engineered to produce an artificial T cell receptor that's used in immunotherapy. So these chimeric antigen receptors are proteins that have been engineered to give T cells the ability to target a specific antigen. In this case, it's CD19. The receptors are chimeric because they combine both antigen binding and T cell activating functions into one single receptor. You may be familiar with this therapy because it's been used previously in patients who've had ALL, NHL, mantle cell lymphomas, multiple myeloma, and it's actually been used for a relatively long time in these diseases. But what about CAR T therapy for SLE? Well, how does this work? So this is really the nitty-gritty of what happens when patients undergo this therapy. We first isolate a patient's leukocytes via leukapheresis, and we sort only the T cells. We transfect the T cells with necessary coding DNA to produce a new receptor capable of recognizing a target antigen. In this case, it's CD19. And once binding to this antigen is achieved, the innate signaling can turn on machinery to destroy the cell that it's recognized. Thus, these CAR T-cell-based therapies can produce a massive immune inflammatory response, which requires inpatient admission for close monitoring. So let's look at the study that Georg talked about yesterday morning. This is published in Nature Medicine, and this is his famous study of 5 patients with systemic lupus who underwent CAR T-cell therapy. So who was included? Those who were included all met EULAR-ACR 2019 criteria. They all had active organ involvement, including renal involvement. WHO class 3 or 4. In addition to lupus nephritis, they all had other organs involved, including heart, lung, and joint. They had to fail to respond to multiple other therapies: steroids, plaquenil, belimumab, azathioprine, mycophenolate mofetil, cyclophosphamide, and rituximab. So these patients were very sick and had tried many medications. They excluded patients who had other autoimmune diseases. They excluded patients who had any CNS lupus, and there was no specified age criteria, but I will note that every patient here was between 18 and 24 years old. There was 5 patients enrolled from a single site in Germany, 1 male and 4 female. Each of them had lupus for 1 to 9 years. And unfortunately, there was no creatinine levels given in the baseline characteristics, but they all had new onset lupus nephritis that was active. So these are the profiles of the 5 patients. You can see that all of them have active serologies. Smith, Smith SSA, nuclear. They all obviously had high titer positive ANAs. They all had lupus nephritis, and they all had activity of other organs, including endocarditis that Georg mentioned the other day. These are all the treatments that they had been on and been refractory to. So here are the results, which again, I know he already went through. You can see that the circulating CAR T numbers in the 5 patients within the first 30 days after treatment all exponentially increased as the B cells decrease. So you see the CAR T cells here with the B cells decreasing here at day 30. What they note is that nephritis ceased in all 5 patients. Arthritis, fatigue, fibrosis of cardiac valves, and lung restriction and diffusion impairment all disappeared after the CAR T therapy. What's interesting about that fatigue portion is that we'll talk about type 1 and type 2 lupus, but we see here an effect of not just the inflammatory components of lupus, but also these type 2 manifestations that decreased at 3 months, which you see here. No, here, fatigue. Interferon alpha was undetectable in the serum of these patients at follow-up. And all DMARD immunologic therapies, including plaquenil and steroids, were discontinued. So what about this therapy? Well, there's a huge risk of cytokine release syndrome, which is a supraphysiologic response following immunotherapy that activates T cells and other immune cells. Symptoms can be progressive and include fever, hypotension, capillary leak, and end organ dysfunction and ICANS. We see, though, that the CRS risk appeared to be much lower than what is seen in malignancy based on prior CAR T cell therapy studies. So far in the rheumatology and the lupus world, this doesn't seem to be such a big risk. Now, some limitations, and I had to update these after we heard his talk yesterday. It is a limited sample size. There were only 5 patients. And the average follow-up was an average of 10 months. Now, he did talk about some data yesterday of the very first lupus patient who is now 600 days out from her CAR T cell therapy, and she is in still drug-free remission, which is pretty incredible. I will note that his population was predominantly Asian and Caucasian. Here at the Cleveland Clinic, our population is mostly African-American and Hispanic. And there was no renal or other tissue biopsy before or after the therapy to document B cell depletion, which is really the crux of this issue. How do we put patients in sustained remission and keep the B cells depleted, both in tissue and peripherally? So that is one component that I guess we'll have to wait and see based on long-term data. So what are my thoughts about this? Well, I do think we're one step closer. You know, precision medicine for lupus is really on the horizon, and soon therapies may be selected based on specific gene expressions and specific gene signatures. I described to you all the different targeted pathways that we now have that are new and upcoming with a huge landscape of trials that are ongoing. I think the CAR T cell therapy, in my opinion, is potentially the most exciting, just given the fact that these patients have been able to sustain drug-free remission. And now that we can show that it's over 600 days, I think that's very promising for all of our very sick lupus patients. And I will wait for questions until the Q.
Thanks for that great talk, Littlejohn. Our next speaker is Dr. Jennifer Rogers. She is currently an assistant professor of medicine in the Department of Rheumatology at Duke University School of Medicine. So after her internal medicine residency, she did her rheumatology fellowship at the University of North Carolina, Chapel Hill School of Medicine. She is the director of the Duke Lupus Clinic, working alongside an exceptional group of physicians. In addition, she participates in research to improve the understanding and treatment of lupus. She has received numerous research grants, including a 5-year grant from the Department of Defense entitled Improving the Quality of Life in SLE by Stratified Personalized Health Planning. So the title of her talk today is Type 1 versus Type 2 Lupus. Dr. Rogers.
All right, thank you so much. It is such an honor to be here at this fantastic meeting and to talk to you today about type 1 and type 2 lupus and our approach really to finding pathways to personalized medicine. I just want to acknowledge all of my colleagues in the Duke Lupus Clinic, my collaborators, especially Dr. Klose-Pozetsky and everyone who contributed to this work today. So today we'll talk about type 1 and type 2, describe mechanisms of type 2 lupus, and discuss our approach to managing type 2 lupus. So many lupus symptoms can be seen and measured. Everyone in this room, I think, knows this. But there are many symptoms that are invisible and can be difficult to measure, and that can include fatigue, pain, brain fog, poor sleep, and often can go hand in hand with depression and anxiety, although not always. Thinking about what causes these symptoms, so lupus symptoms, I would argue all of them are due to a complex interaction between biologic, of course, autoimmune, genetic predispositions, age, if there are comorbidities, but also psychological factors, including our memories, our fear, our attention on those feelings, but also our beliefs, right? Our beliefs about medications, should I take this or not? Our beliefs about vaccines, our beliefs about our symptoms. Embedded within their social relationships, is there support? Is there lack of support? Is there trust in the healthcare system and within the environment, including exposure for infections? We had a good discussion last night about the role infection may play. But also when I mean environment, I also mean access to care, right? Ongoing stress within our society, including public policy, insurance, and access to insurance. All of these factors, right, contribute to health behaviors, which can contribute to the manifestations symptoms. So when I think about pathogenesis, this is a simplified version. It's probably 10 years old now. In addition to the genetic and immunoregulatory factors that we heard about in the beautiful presentation earlier, I would add psychological, social, and environmental factors are important to the development of lupus manifestations, including organ damage, but also those symptoms of fatigue, pain, and brain fog. We know these symptoms can be debilitating. They can occur during times of flare or remission. They're often not really associated with serologies consistently. They can be difficult to treat, right, because they're often multifactorial. We know that they negatively impact quality of life, work and school productivity, relationships, and family. And in our cohort at Duke, at least, they're very highly associated with high rates of disability. We know in the literature that there's a clear discordance between patient and physician's perception of lupus activity and their concerns at the visit. There's also pretty well-known quarterly correlation between patient-reported outcome measures and physician-recorded lupus activity. All of this can lead to discordance, right, and frustration for both patients, but also rheumatologists. We conducted qualitative interviews with 42 lupus patients and 13 rheumatologists, including lupologists across the country, and asked their input about lupus symptoms. And we had one rheumatologist tell us, I feel helpless when a patient comes in my office. She has a perfect immune profile. I can't find synovitis. She can't function. There's a gap between these two concepts of flare and activity. A patient told us, we've had doctors tell us it's all in our head. So every time a doctor minimizes or blows off a symptom, it makes me go back to that same feeling, it's all in my head. And we know that this discordance can lead to poor communication and has important implications for patient outcomes. In lupus, when there's poor communication, it has been associated with increased rates of flare and increased rates of organ damage. Conversely, in lupus, when patients have good patient-physician relationships, they have higher levels of adherence, which we know especially is important for our nephritis patients. So we developed at Duke this type 1 and type 2 model, really with the goal to bridge this gap, right, these two views, and to encompass all aspects of lupus symptomatology and how we manage our patients. So in this model, first of all, everybody has lupus. So everyone has met, you have diagnosed them with lupus, and this is a manifestation or a symptom model. Type 1 are those classic symptoms, synovitis, nephritis, discoid lupus. And type 2 are those intangible symptoms, the fatigue, the brain fog, waking unrefreshed. Many times patients have both, right? They have mixed symptoms. And of course, our goal is reaching minimal disease activity. And the severity of both can change over time. How do we measure type 1? I think like everyone in this room, we use the SLEDAI and the PGA for our assessments. And then how we measure type 2, we are using the polysymptomatic distress scale, which is a patient-reported outcome measure that everyone comes in the door, they fill this out, and you can assess where they're hurting, the level of fatigue, the level of brain fog, and the amount of depression. Others have used the short form 36 and found similar rates of type 2, and we've done this also with the PROMIS 29, but we like the simplicity of this form because it's quick and easy to use. We've also developed the type 2 PGA, which is a validated measure similar to type 1 PGA for scoring the amount of type 2 activity. So in our cohort, this was a cross-sectional cohort of 300 patients, using the SLEDAI and the polysymptomatic distress score, you could really subpopulate patients. So in our cohort, about 40% of people had relatively low disease activity. About 20% had low type 1, but were really not feeling well with a significant amount of polysymptomatic distress. And about 30% of patients, right, would qualify for kind of the standard clinical trial, the SLEDAI more than 6 and relatively low amount of polysymptomatic distress. Importantly, the smaller subset in red are those nephritis patients, right, that have the highest amount of activity and probably the lowest amount of symptom burden. And then a smaller population have both mixed. In thinking about who are these patients and who are these populations, patients that have any degree of type 2, whether that's purely type 2 with a minimal amount of type 1 or mixed type 2 with active type 1, they will report the greatest amount of flares. They will also report the highest level of patient global assessments of their disease activity, significantly more than those with just pure type 1 lupus. Likewise, patients with any amount of type 2 lupus will not only, of course, report to you more pain and fatigue, but they're more likely to report symptoms which classically we would think of as type 1, right? Swollen joints, alopecia, oral ulcers, shortness of breath. So I think this is important to keep in mind when you're using PROs and lupus or reviewing the self-reported flare literature, right? To think about what do patients mean and what symptoms are they reporting. So how does this change over time? We just finished, this is not yet published, we just finished this project. It was a longitudinal study of 300 patients following how does their type 1 and type 2 change over time. These are the trajectories of each individual patient over 36 months. And what we found actually using quadratic modeling was that the patients actually kind of fell back into those 4 main groups. And then a smaller subset we weren't able to model. So in our cohort, the difference mainly in looking at baseline demographics and baseline clinical variables, type 1 patients that purely had type 1 were mostly nephritis and they were much younger. And our type 2 patients were older and had the highest rates of disability. But there was no difference otherwise in social support or racial ethnic breakup or clinical manifestations. Do type 1 and type 2 lupus change together, right? This is the important question of how are they related? So looking at these 300 patients, we had almost 2,000 visits or total changes that we could track. And we found about 40% of the time, patients type 1 and type 2 correlated together. Either they improved together, they got worse together, or they stayed the same. Whereas more than 50% of the time, right, the changes were either discordant or didn't have a clear pattern. We know also that type 2 symptoms can be associated with type 1 inflammation, right? This comes from the Biologic studies where patients that reached an SRI-4 response with therapy were more likely also to have an improvement in quality of life measures as measured by the short form 36. So this led us back to those qualitative interviews with our 42 patients that we had a breakdown of mixed minimal type 2 and type 1 patients. And we looked at the patterns. How do they describe what has been their pattern, their trajectory through their course of lupus, and really kind of uncovered and changed our thinking in that you can think about type 2, I think, in 2 main patterns. There's intermittent type 2 that can be more often associated with type 1. In our cohort, they were much younger. They were more often Black females, and they had more internal organ manifestations. Whereas a subset of patients, everyone again has lupus, right? A subset of patients had persistent type 2. They were older, they were less likely to be Black patients in our cohort, and they had less internal organ and less nephritis manifestations. So we've changed our model. So everyone again has type 1, right? Otherwise they wouldn't be here. And then we have a subset that has intermittent type 2. And perhaps these patients, their fatigue, as we heard about with CAR T cells, could improve with immune therapy. But then there's a subset of patients that really have persistent type 2. It's important to identify those, right? Because those patients do not need more steroids. We should be sparing their steroids for their flares and focusing on other mechanisms that can help them. And of course, we have patients that have mixed symptoms as well. All right, what are the mechanisms of type 2? So again, I go back to my biopsychosocial factors that can predispose and precipitate. And then importantly, I think perpetuate these symptoms, right? And it's important to kind of understand these with our patients. Why is that important? These symptoms really are constructed in numerous parts of the brain. We see the frontal cortex involved with our thoughts. We have the amygdala and hypothalamus involved in our emotions and our memory. We have the prefrontal cortex involved in our attention and decision-making. So all of these areas of the brain, right, can become activated by numerous cellular mechanisms to increase activation, to stimulate and increase sensitivity and strengthen those maladaptive synaptic connections. When this happens, right, we have this cycle of amplification, which then affects behavior. So patients are avoidant, they're isolated, they're less mobile, they're having more anxiety. Patients will come to you and tell you they're exhausted. They're tired, but their brain is activated, right? And so they're not able to sleep and they're wired. And we know that sleep is really essential for neurogenic restoration and to trim those dendritic spines. Likewise, exercise has similar positive effects on sleep and synaptic plasticity. Thinking specifically about lupus patients, right, so that's chronic pain, but the neuroimmunology of lupus patients, lupus can affect numerous parts of our nervous system, as we know, the central, peripheral, and autonomic nervous system. There's often, with exceptions, of course, in CNS lupus, a paucity of measurable CNS inflammation, and so suggests there are other pathways, not just inflammation, that can be involved. We know in lupus in particular, we see changes in synaptic plasticity, changes in long-term potentiation, and impaired adult neurogenesis. Some studies have also suggested disruption of the blood-brain barrier, and about 30 to 50% of patients can have positive anti-NMDAR antibodies with aberrant cytokine and chemokine signaling. Moreover, we know in lupus in particular, there are biologic abnormalities that can contribute to these type 2 symptoms. So very elegant studies using functional MRI. We can see patients, of course, have vascular compromise or infarct or hemorrhage, but separate from that, we have seen areas of volume loss, importantly in the hippocampus and the amygdala. In addition to volume loss, these studies have demonstrated decreased neuronal cell loss in the amygdala, which is important because, right, this is where we're regulating our mood and our emotions. And so when we have cell loss in these areas, patients can have emotional ability, it can increase their sensitivity to stimuli and impair their judgment, and importantly, impair their trust or decision-making. All of this, of course, has impact on emotional and psychosocial function. There's not a clear-cut battery of neuropsych testing yet, at least for lupus patients, but across the board, in looking at neuropsych testing, about 20% of patients can have impairment in attention and processing, which is important to note. So how do we manage, what is our approach to manage type 2 lupus? So really it's kind of based with this idea of the empathy wheel, which I love this slide, right? So we're listening to our patients, we're understanding these biopsychosocial factors that are perpetuating or contributing to their symptoms, we're relating and connecting, validating their symptoms. And then the third most important, right, is reaching back out and demonstrating our empathy in a non-judgmental way. At all of our visits, we assess a type 1 PGA and a type 2 PGA, and then we have an assessment and plan for both. Then you can follow them, right, over time to see if somebody's improving or having worsening type 1 or type 2. We just finished this fantastic CTSI project. It was a multidisciplinary group that we brought together over this past year with adult and pediatric rheumatologists. We had lupus patients, but we also had psychology, palliative medicine, internal medicine, neurology come together and discuss how do they manage these symptoms in their unique populations. And it was a great project. We learned a lot from them. And in these discussions in this project we just finished, there's kind of two main themes of management. One is changing patients' experience of their symptoms, working on that therapeutic relations, working on self-acceptance, changing patients' symptom understanding, which of course involves lifestyle intervention, and then two, changing the level of symptoms. And so here we talk about reframing, pacing, setting goals, coping strategies to manage these symptoms. Across the board in our study, the group told us that building that therapeutic relationship was really important, right? Oftentimes patients won't be ready. They don't want to go see another pain psychologist. And so you have to build trust. You have to have buy-in. And often in my experience, this takes several visits that you're planting the seed and using words, again, telling patients, I'm here to work with you. How do we get you from here to a better place goes a long way for their buy-in. We, of course, use medications and incorporate those. I think clearly if there's underlying mood disorders, we have to treat the underlying mood disorders. And I think everyone in this room probably uses a variety of these medications, right, for chronic pain. But there is not one medication that works for type 2 lupus or chronic pain. And so really the idea is moving beyond just giving medications. My patients on average, right, take 6 to 10 to more medications, and adding another pill is often not what they want, especially when we need to focus on patients taking their Cellcept or Plaquenil rate. Of course, we want to avoid narcotics and benzos, and we're minimizing sleep medications. Over the long run, they're not helpful and don't result in that restorative sleep. So really, multidisciplinary collaboration is essential. I don't think I am not trained to do any of these things, so we have to work with our colleagues. Of course, referring to pain psychology, CBT, or ACT can be very helpful. What I learned in this group that was new was that referring for specific CBTI for insomnia can be very helpful, and placing referrals to speech therapy to work on executive functioning skills. Remember, many patients suffer from attention and processing disorders, And so having someone help organize and cope can really move them forward in managing their day-to-day. Most of us, I think, refer to physical therapy, especially aquatic therapy. If patients have resources, alternative medicine is an option for some patients. And I think in the future, other devices, vagus nerve stimulation is being studied in lupus. Some patients use virtual reality. And I think for patients with severe depression and anxiety, TMS can be really helpful, and I think potentially promising for chronic pain as well, but we will see. From a patient standpoint, we talk a lot about acceptance and regaining control, right? And so you have to manage patients' expectations with the goal to build self-efficacy, because they have to actively be involved in their own therapy. I talk a lot actually, to try to explain to my patients that their social, emotional, and physical health are intertwined. But you have to remember back to that slide, patients have heard that a lot. So you have to be very careful when you're talking about this. They don't hear you say, it's all in my head. So this quote from Rachel Zoffness, who is a pain psychologist at UCSF, is in our CTSI group, it's fantastic, uses terms like the brain's connected to your body 100% of the time, to make the point that patients need to understand that the emotions and fear can contribute to that pain feelings and exacerbate those symptoms, with the goal really being to reset alarm and reset their pain symptoms to turn down that symptom dial. So what is our approach? We talk a lot about setting SMART goals and then adjusting those goals if patients aren't meeting them, with the goal to increase feelings of safety by deactivating those brain fear circuits. And I send patients a lot to various apps or paid workbooks I think can be very helpful. We talk a lot about strategies, so mindfulness, distraction. I talk about finding joy or meeting or gratitude exercises. I think all of these are helpful, and I have a little dot phrase that I put in my ABS so patients can go back and remember what we talked about. Gradual exposure is important, so I try not to use the term exercise and talk about movement and gradually increasing movement. Relaxation techniques, again, I refer patients for relaxation techniques, diaphragmatic breathing, and I think importantly, getting back out in social activities or being part of patient support groups. You know, we're actively involved in our North Carolina LFA. I think empowers patients and gets them up and moving. And so finally, really, it's about pacing, right, and regaining control. All of this takes time. I think talking a lot about patients to prepare for setbacks. You know, in these visits, patients will tell you that the weather flare symptoms or stress flare symptoms, or more often not taking their medications right, can flare symptoms. And so having a plan and giving them hope, because I do believe that patients have the power to improve their experience of type 2 lupus. So in summary, I think we talked about the type 1, type 2 model. In our practice, we use a lot of patient-reported outcome measures, not only in research in our clinic, but we use them clinically every day. We address the wide spectrum of lupus symptomatology, and remembering that all lupus symptoms, especially type 2, but I think all lupus symptoms are biological, cognitive, emotional, and contextual, and really working with a broad team of specialists in viewing type 2 lupus or these symptoms, right, as an opportunity to improve the life of the person across the room who may be suffering. So with that, I thank you very much. And of course, thank all of our Duke Lupus Registry participants who have contributed as well.